Welcome to the workshop, Introduction to Chronic Graft-versus-Host Disease. My name is Michaela O'Brien, and I will be your moderator for this workshop. I'd like to thank Sanofi, Incyte Corporation, Pharmacyclics, an AbbVie company, and the William G. Pomeroy Foundation, whose support helped make this workshop possible. It is now my pleasure to introduce today's speaker, Dr. Andrew Harris. Dr. Harris chose a career in transplantation and cellular therapy after he underwent a transplant for acute leukemia while in college. He has been a pediatric transplant and cellular therapy specialist for 12 years and serves as the medical director for the Memorial Sloan Kettering Kids Pediatric Multidisciplinary GVHD Clinic. Dr. Harris performs clinical trials for patients with both acute and chronic graft-versus-host disease and serves on several national and international committees in the field of transplantation and cellular therapies, with a focus on cancers and post-transplant complications. Please join me today in welcoming Dr. Harris.
Thanks, Michaela, and welcome everybody to my talk. I'm going to be talking with you all today, giving an introduction to graft-versus-host disease, and since that's a mouthful, I'm going to be referring to it as GVHD going forward. So the learning objectives for my talk today are to discuss the differences between acute and chronic GVHD, discuss the different sites or parts of the body, namely the organs and the tissues that are typically affected by graft-versus-host disease, talk about the incidence, which means how often it occurs, and the typical onset of acute and chronic graft-versus-host disease. Next, we will talk about some therapies to prevent and to treat both acute and chronic GVHD, as well as some side effects of these therapies. And last but not least, I will be talking about some physical and emotional challenges associated with GVHD and its treatment. Please keep in mind that there are a lot of excellent sessions by colleagues, and many of whom I consider friends, that go into much more detail about a lot of these different unique topics that I'll be addressing today in this introductory talk. So I'd like to first start off by explaining to you how bone marrow transplants or stem cell transplants in general cure cancers like leukemia, lymphoma, MDS, and other related diseases. So on the right, you'll see a picture of a person that is the patient, also known as the host. And when they get leukemia, lymphoma, or one of these other diseases, they have a significant amount of cancer in their body, represented by these black circles. When they're first diagnosed, we treat them with standard immunotherapies, chemotherapies, and radiation to get this cancer burden down to a very low level, and in many instances down to a level that we can't detect with our imaging and our bone marrow testing and other tests as well. And at this point in time, for patients with high-risk diseases, they will often go forward with a transplant. When we give a transplant, we take the bone marrow or the stem cell graft from a donor, and for a majority of these grafts, they consist of the blood stem cells, and these are the cells that will go on to grow up to be all of our white blood cells, our red blood cells, our platelets, and our immune system. But often they are accompanied by immune cells that are collected at the same time as these stem cells. We give patients chemotherapy, immunotherapy, and radiation in different combinations for different diseases to get their body ready to receive this transplant. And when we transplant these cells into the patient, these immune cells will, over time, eradicate any of these residual cancer cells in the patient. Unfortunately, sometimes these immune cells can also attack the healthy parts of the patient. And when this occurs, this is that graft-versus-host disease, or the donor immune system versus the patient, and that is what GVHD is. So there are two major forms of graft-versus-host disease that we talk about. The first is acute graft-versus-host disease, and this form of graft-versus-host disease typically occurs earlier after transplant. This primarily affects the skin, the digestive tract, and the liver, and is considered more of an inflammatory process. On the other hand, there is chronic graft-versus-host disease, which typically does not occur until at least 2 months after transplant, but can occur much, much later, as we'll talk about in later slides, and it can affect most parts of the body. Chronic graft-versus-host disease more closely resembles autoimmune diseases, whereas acute GVHD does not. When both of these are occurring simultaneously, it's referred to as overlap syndrome or overlap GVHD, which you may hear a doctor talk about if you or a loved one is experiencing this particular manifestation of GVHD. So there are a lot of different ways to try to prevent graft-versus-host disease. One of the ways that we can do this is by manipulating that graft, so those cells that we collect from the donor, before we give them into the patient. And I'm going to talk about those different ways that are currently being done and some of the future ones that are being explored. The first method is through T-cell depletion or CD34 selection. Well, so these T cells are thought to be the major drivers and effector cells. They're part of the immune system, and they are thought to be the cells that cause graft-versus-host disease. These are also the cells that are thought to help prevent against infection and recover the immune system. So when we get rid of these cells, this can be associated with an increased risk for some infections and slower recovery of the immune system in general. I forgot to mention that CD34 selection is another way to get rid of these T cells, whereas opposed to getting rid of the T cells, we select just those stem cells themselves, and all the other cells are discarded. And both of those result in a very pure product of stem cells that we transplant into patients. This is not being done at most centers as we've become much more savvy in how we've been able to manipulate these grafts. And one of the more common ways we manipulate grafts now is what's called an alpha-beta T cell and B cell depleted graft. And in this, we get rid of a large number of the T cells, and there are two major types of T cells. There are alpha-beta T cells, and there are gamma-delta T cells. And it's thought that the alpha-beta T cells are the ones that cause graft-versus-host disease, while the gamma-delta T cells are important for helping protect against infection and to help fight off that cancer that we're trying to cure with the transplant. This is felt to improve the risk for infections, risk of relapse, and also keep the rates of graft-versus-host disease quite low. Last, there are some newer strategies that are currently being investigated at some centers. Some centers are doing what is called naive T cell depletion, where they get rid of any T cells that have not already been trained to attack specific infections and other proteins and things like that. And this is thought to reduce graft-versus-host disease while minimizing risk for infection and helps keep the risk for relapse low. And there's a new product being made by a pharmaceutical company that's called an ORCA-T graft that is being explored in clinical trials right now. For patients that do not have these graft manipulations done, we use medications to try to prevent graft-versus-host disease. I'm going to go over those over these next several slides. The first two agents that are used are called calcineurin inhibitors. Their names are cyclosporine and tacrolimus. Tacrolimus is also called Prograft or FK506. If you hear those names, they're the same drug. And for cyclosporine, its trade name is Neoral. These are immunosuppressive medications that are also used to prevent rejection for patients that get solid organ transplants, like a heart transplant or a liver transplant or kidneys or a liver. Typically, these medications are started before the day of transplant and continued on for anywhere from 2 to 6 months before we start to taper them off. Unfortunately, these drugs can be very finicky, and we have to keep them in a very controlled level in the bloodstream for patients. So we have to monitor drug levels, because if they get too low, they don't reduce the risk for graft-versus-host disease because they're not being immunosuppressive enough. But if they get too high, they're associated with a lot of toxic side effects that can affect the nervous system, affect the kidneys, and things like that. Even when these drugs are being used at the appropriate levels, and we're always changing these, the doses for patients to keep in these levels, they can be harmful to the kidneys, they can cause some higher blood pressures, and they can cause low magnesium levels in the blood that can be dangerous if we don't replace magnesium for patients either by IV or with oral replacements. So many of our patients that are on either cyclosporine or tacrolimus will need some magnesium supplementation. And last, for cyclosporine, it can cause thickening of the gums and cause excess hair growth for patients. So this is one of those things that can lead to some body issues for patients, which is a challenge, particularly for adolescents and adults. The next medication I'd like to talk about is methotrexate, and this is a chemotherapy agent that can be used to treat cancer, but is also used at lower doses to treat autoimmune diseases. When we use methotrexate to prevent graft-versus-host disease, we give it at those lower doses more comparable to what's being used to treat autoimmune diseases. We often will give methotrexate on days 1, 3, 6, and 11 after the transplanted cells go in. And when we give this medicine, it tends to be very well tolerated, but it can worsen the mouth sores that patients experience from the chemotherapy and radiation that they receive to get their body ready to receive the transplant. And when we get these sores in the mouth and throughout the digestive tract, we refer to this as mucositis. There's a couple important times when we cannot give methotrexate even if we had planned to use it. If a patient has a significant liver injury, either from their chemotherapy or coming into their transplant, we cannot use the methotrexate because it doesn't get cleared by the body and leads to much higher exposures and toxicities to it. And if patients have any fluid collections, these are called effusions or ascites, so collections of fluid around the lungs, collections of fluids in their tummy, collection of fluid around the heart, we can't give this methotrexate because it will pool in those fluids and cause additional toxicities and will slowly get back out into the system and give longer exposures as well. Another agent that we use is called mycophenolate. This is also known as MMF for short, or Cellcept or Myfortic. And this is typically started around the time of transplant and continued for the first month after transplant. This agent can cause some lower blood counts for patients, and it can also cause gastrointestinal symptoms of nausea, vomiting, diarrhea, or sometimes abdominal pain. Unfortunately, these symptoms can overlap with graft-versus-host-disease that affects the GI tract. And so it can be difficult sometimes to differentiate if these side effects these symptoms are related to side effects from the medication or related to GVHD, and it takes seasoned and expert pathologists talking with your transplant doctor to try to determine what they feel is the most likely etiology if we have these symptoms occur when we're at risk for GVHD and on this medication. Another agent that is used in some centers is sirolimus, also known as rapamycin. If it is used, it's typically used in place of tacrolimus or cyclosporine. This medicine can also be harmful to the kidneys, and just like cyclosporine and tacrolimus, we do have to monitor levels of this drug to keep it in a narrow target range. This agent can cause high blood triglyceride and cholesterol levels, so this needs to be monitored for patients to make sure that we don't have high, fat or cholesterol levels in their blood, which can cause additional side effects and injury to the liver and other organs. Another agent that's being used more and more widely for patients is cyclophosphamide given after transplant. This is an agent that we have decades of experience using to treat cancer, and it's really been over the past 10 years that we've learned how to use it very effectively in the early post-transplant setting to reduce the incidence of graft-versus-host-disease. When this agent is used, it's typically given on days 3 and 4 after transplant. While it's being administered, it can cause some nausea and vomiting, and when it's process broke down and cleared by the body, one of the toxic byproducts can be very irritating to the bladder, can even cause injury and bleeding from the bladder. And in order to minimize this, we give patients extra fluids by IV and an IV medicine called Mesna that binds up this toxic byproduct of this medicine to help minimize the risk for the bladder irritation that we can see. The newest agent on the block for the prevention of graft-versus-host-disease is a medicine called abatacept. And this is an IV medicine that currently is approved to be given in 4 doses over the first month after transplant. It tends to be very well tolerated, but may cause some higher blood pressures in patients. It's currently being explored in multiple different settings, but it's most widely used right now for patients for whom we don't have a perfectly matched donor for their transplant. It's been shown to help decrease the risk for GVHD to equalize that with patients that are getting a fully matched transplant from an unrelated donor or from a stranger. So we combine all these medicines in different combinations in different patients in different settings in order to try to prevent graft-versus-host-disease. So the backbone for most of these strategies is using either tacrolimus, cyclosporine, or sirolimus combined with either methotrexate, and this is most commonly used for patients that are getting a fully matched transplant from a sibling or from a fully matched transplant from an unrelated or stranger who's their donor. Mycophenolate will be combined instead of methotrexate with tacrolimus, cyclosporine, or sirolimus in a lot of different settings. One of the more common ones is if we use a cord blood unit as our graft that is transplanted to the patients, but we also will use it in patients where we're worried about bad mouth sores, liver dysfunction, or if they have other pre-existing conditions where we worry about the safety of giving methotrexate. One of the more popular regimens that's being used, this is something that's being used for a lot of transplants from half-matched related donors, so from a sibling, a parent, or a child, and now being more widely used with matched unrelated donor transplant and slightly mismatched unrelated donor transplants is this post-transplant cyclophosphamide, followed by the use of tacrolimus and mycophenolate. And the last of the common combinations that's being used now is abatacept given in combination with tacrolimus and methotrexate. This is most widely being used following a less than perfectly matched stranger donor transplant, and it's being investigated in different settings as well. So when a doctor chooses one of these different regimens or something else entirely for the patient, it's based on how the patient's getting the transplant, if they're going to be getting a fully ablative or reduced intensity regimen that prepares them for the transplant, what comorbidities the patient has, meaning what other problems they have in their body as a result of their treatments and their health, what type of donor we're using and how well they're matched. And so these are all personalized to each individual patient and how their transplant is going to run. So moving on now to acute graft-versus-host disease, incidence meaning how often it occurs and how it typically looks when it does show up. Acute GVHD can occur in anywhere from 1 in 4 patients to 7 out of 10 patients, depending on how old the patient is, the type of transplant that's being done, which donor is being used, and other additional risk factors. For a majority of adults, we cite anywhere from 40 to 50% of them will experience graft-versus-host disease that's going to require systemic therapy, meaning therapy by IV or by mouth. It most often occurs anywhere from 2 weeks after transplant through the first 2 months of transplant, but it can occur much later. And with some of the newer strategies that we're using for transplant, we are seeing acute GVHD occurring a little bit later on, sometimes beyond even 6 months after the transplant. And when acute GVHD does occur, it can involve any combination of skin involvement, digestive tract involvement, or liver involvement. So when acute graft-versus-host disease involves the skin, this is the most commonly involved site that we see acute GVHD affecting in our patients. It typically presents as a red rash that can be either splotchy or more widespread. It can come in patches. Sometimes you'll see little raised bumps. Sometimes you'll see flat patches of red skin. But when it's most severe, it can cause large blisters on the skin or sloughing of the skin. And although this is rare, it can be extremely life-threatening. And we often have to utilize the expertise of our burn doctors, our burn specialist doctors. So since I'm a pediatrician, the pictures you're seeing are going to be of children, but these are similar appearances that are also seen in adults. On the left here, you see a foot that has redness over the sole, and the soles of the feet and the palms of the hands are often affected and involved with skin GVHD when it's present. The middle picture, you see a child's back that we have these red bumps and red patches all over, and it's also involving much more of this patient's skin, the arms. If it's on the back, it's most likely also on the front of the torso, and it's probably affecting this child's legs as well. And this patient on the far right, you can see on the left side of their back an open wound from where there was a large blister that had opened up. And on the back of the right shoulder, you see a dressing over another area that was another blister that had opened up as well. And that is that most severe form of skin GVHD that we rarely see but can occur. When acute graft-versus-host disease involves the digestive tract, we divide that into the upper digestive tract and the lower digestive tract. When it involves the upper gastrointestinal area, the symptoms that are experienced by the patient are constant and pervasive nausea. Some will have frequent frequent vomiting, and some will have a loss of appetite with associated weight loss. So we can see any combination of these three in patients that have GVHD affecting their upper digestive tract. When patients have GVHD affecting the lower digestive tract, this is the smaller intestine or large intestine, also known as the colon. This typically presents with watery diarrhea, 3 or more episodes a day. There may be associated crampy pain that occurs with the diarrhea and gets better after stooling. But at its most severe, lower gastrointestinal acute graft-versus-host disease can lead to persistent severe pain requiring IV pain medicines or having blood in the stool. Acute graft-versus-host disease can also affect the liver, and the liver is the least commonly involved site of acute graft-versus-host disease. And when we see acute graft-versus-host disease of the liver, this presents with increased bilirubin on blood tests, and what is seen clinically is jaundice, which is yellowing of the eyes or the skin and darkening of the urine because of this increased bilirubin in the bloodstream. This is typically painless, although some patients can be itchy with this. It just can get quite severe in some patients. And we grade the severity of liver GVHD based on how high that bilirubin level gets in the blood. So moving on to the treatment of acute GVHD, for mild skin involvement, meaning skin involvement that there's less than half of the body is covered with red involvement of acute GVHD, we can often get by with just using topical steroid creams and ointments. For GVHD that affects just the upper gastrointestinal tract, sometimes we will try to treat them with non-absorbable steroids that we take by mouth that are thought to be a topical coating of steroids for the upper GI tract. The two different steroids that we use for this are called budesonide and beclomethasone. But for all other GVHD, so skin involvement that involves more than half the body surface area, for GVHD affecting the lower GI tract, or for GVHD affecting the liver, we need to use systemic therapy, which means oral or IV steroids is the typical first agent that's used. There are a lot of clinical trials that are currently being performed at multiple different centers that look at adding a second agent to steroids as a way of decreasing our overall use of steroids because of all the side effects, both short-term and long-term, that we associate with steroid use. And we will talk about those in another few slides. Treatment for acute graft-versus-host disease typically happens over several weeks to a couple months. So this is a much shorter period of treatment than what we do for chronic GVHD, which treatment is typically months to sometimes even to years. So when I talk to patients about treatment of acute GVHD, I tell them this is the sprint to the marathon of treatment that it is for chronic graft-versus-host disease. So when we start treatment with steroids for a patient with acute graft-versus-host disease, more often than not, we use twice daily dosing, and we give this first higher dose for anywhere from a minimum of 5 days to longer. And if it's improving well, we try to decrease the steroids fairly quickly because steroids have a lot of potential side effects. And these include weight gain all over the body, but also the rounding of the cheeks and that moon facies that sometimes you'll hear someone talk about. Steroids at higher doses are associated with mood swings and sleep disruption. Patients can get very angry or emotionally labile. Steroids can cause high blood sugars, high blood pressures. Some patients will need to go on insulin or other diabetes medications if their blood sugars stay high. And some patients will also need to be put on blood pressure medications as a result of their steroid therapy. Thankfully, when we get down and off of these steroids, the higher blood sugars and higher blood pressures typically will go away, but not always. And the weight gain will go away over time. While we're on these higher doses of steroids, because it is very, very immunosuppressive, our patients are at risk for infections. So bacteria, fungus, molds, and viruses are all risk for patients that are on high doses of steroids. And when we have to use steroids for longer periods of time, they weaken our bones, which gives us concerns for bone health as a long-term effect. So patients can have osteoporosis, low bone mineral density, also known as osteopenia, or they can actually have effective killing of bone in the joints, which is called avascular necrosis. So for patients that don't have a good response to steroids or a complete response to steroids, we have to talk about using different medicines, and this is second or beyond line treatment for their graft-versus-host disease. When graft-versus-host disease does not respond well to steroids, it's very worrisome to us doctors because we know we're in for a big fight and that our patients are at risk for bad outcomes for their transplant. Thankfully, we've had a few different medications that have been studied and approved for treatment of GVHD that does not respond well to steroids. The first of them is ruxolitinib, also known as Jakafi. This is an oral medication that's given twice a day to patients. Its major side effect that we have to watch when we start a patient on this medicine is it can cause low blood counts. So when a doctor starts a patient on Jakafi, they're typically checking blood counts once or twice a week to make sure that their blood counts are staying in safe ranges. When they've been on this medication for a period of time, if we don't see the lower blood counts, that monitoring can go much less frequently. And so ruxolitinib is the only FDA-approved second-line therapy for acute graft-versus-host disease. But there's another treatment called extracorporeal photopheresis, or ECP, because that's a mouthful. And this is a treatment where we take patients, we hook them up to a machine where we can run their blood through the machine and collect out the white blood cells and expose those cells to UV light and then infuse those cells back into the patient. This is not as immunosuppressive as a lot of the other agents and can be fairly effective in treating GVHD, but it's typically given twice a week initially, and each treatment is roughly 3 to 4 hours. And so this is a big time commitment, which can be hugely impactful on quality of life for patients. So we try to use other agents first typically, but this is a good option for patients that either can't tolerate other agents or don't respond to other agents. After we see them responding to ECP, if they respond to ECP, we can start spacing out the treatments from twice a week to twice every other week and then further out from there. There are a lot of clinical trials that are currently underway for treatment of graft-versus-host disease that does not respond well to steroids. To list just a few, there are mesenchymal stem cells, there are hormones such as chorionic gonadotropin, and there's a whole slew of new medicines that are actively being explored. So many centers will have at least one clinical trial open for patients that have acute GVHD and not responding to steroids. And whatever study is open at the center that you're at, they often will discuss this study with you and ask you to participate to help us learn if this medicine is effective, so that way we can start using it for more patients, but also because it may be of benefit to you as a patient. Moving on from acute GVHD to chronic GVHD. Chronic GVHD typically occurs anywhere from 15 to 40% of patients, depending on the patient's age, the transplant type, and other risk factors like did the patient have significant acute graft-versus-host disease earlier, which does put them at higher risk for chronic graft-versus-host disease later on in their course. Chronic GVHD most often occurs between 4 months and 2 years post-transplant, but it may occur sooner, and the earliest cases I've seen are roughly 2 months out from transplant. And in rare cases, it can happen beyond 2 years out post-transplant. So this lifelong follow-up is important for our patients. Chronic graft-versus-host disease can involve almost any body site or any combination of body sites when it occurs for our patients. Here is a list of some of the more common sites of chronic graft-versus-host disease, and I'll go through these with you. So for the eyes, the symptoms that patients will often have are light sensitivity, dry eyes, or a gritty sensation in the eyes like there's something in them. They can have excessive tearing. They can have pain in their eyes or redness. For the lungs, this is one of the organs we worry most about because it can be extremely severe and life-threatening. The symptoms that are experienced by patients can be shortness of breath or increased intolerance to activity, cough. They can have an emphysema-like picture. They can experience frequent lung infections. That can be a red flag that there is chronic GVHD present in the lungs, or they can develop fluid collections around the lungs. For the skin, we can see thickening of the skin. We can see scarring or stiffness of the skin, and these are more worrisome when they occur. But we can also see dryness, color changes of the skin, nail changes, itchiness, things like that. That can also be manifestations of chronic graft-versus-host disease of the skin. It can affect the mouth and cause redness of the gums and the cheeks and the tongue. It can cause sores or bumps in the oral cavity or the mouth. It can cause mouth dryness, or it can cause sensitivity, particularly to foods such as minty foods and toothpaste, acidic foods, things like that. GVHD can also affect any part of the digestive tract. Excuse me. And if it affects the esophagus, that can lead to food getting stuck or difficulty swallowing. It can lead to choking on food when eating. When it affects the lower GI tract, it can cause constipation or diarrhea. GVHD can also affect the genitals when chronic GVHD is present. It can lead to irritation or disfigurement of the penis for males. It can lead to scarring, narrowing, painless sex, or extreme dryness for females. And last of the common sites for chronic GVHD are the muscles and joints, and they can lead to limited mobility or loss of flexibility. It can lead to muscle cramping and pain. There are also some more recently recognized less common sites for chronic graft-versus-host disease. The scalp can have thickening of the skin, often with flaking or sometimes with hair loss that may or may not be associated with scarring. It can affect the brain and lead to personality and speech changes, seizures, weakness, confusion, or sleepiness. This tends to be fairly uncommon, but something to keep in mind that this is something that's recognized as a manifestation of chronic graft-versus-host disease. It can cause a fluid collection around the heart called a pericardial effusion. It can affect the kidneys, leading to injury to the kidneys, which is shown on blood tests, or it can lead to patients losing a lot of their blood proteins in their urine, and this looks like foamy urine to our patients. Last but not least, the immune system that affects and causes GVHD can also attack blood counts and lead to life-threateningly low blood counts because they're being destroyed. So there are a lot of different treatments for chronic graft-versus-host disease, and whenever we can give treatments locally to different areas that are affected, that's always preferable because we know our systemic therapies have a lot more side effects. So for the skin, we have a lot of different options. There are topical steroid creams and ointments that we can use for chronic GVHD, just like we use for acute GVHD. Because dryness is a very common problem post-transplant, especially in patients with chronic GVHD of the skin, we do want patients using hypoallergenic moisturizers for the skin. There are a lot of other prescription creams and ointments that can be used for patients. There are topical formulations of tacrolimus, of ruxolitinib, and other agents that can be used. And we can also use UV therapy directly to the skin as well. For the mouth, we have steroid mouthwashes that patients can switch to decrease that inflammation and irritation in the mouth. And we also have light therapies that are under investigation or are thought to help with treating the symptoms and the GVHD of the mouth. For the eyes, many patients will be placed in artificial tears, but there are prescription drops that are either steroids or other immunosuppressants that can be used as well. And beyond these, there are surgical approaches and specialized contact lenses that can be used for the eyes. One thing you'll note is most of our topicals, we have a steroid form that we can use topically for patients because steroids continue to be our best and most reliable agent for treating graft-versus-host disease. There are some specialized treatments for the lungs if the lungs are involved, and this is something that is frequently used in patients when there's concern for lung GVHD. We refer to this as FAM therapy, and what that consists of are three different agents. An inhaled steroid, similar to the inhaled steroids that are used for patients with moderate to severe asthma. There's a medicine called azithromycin that many patients will be placed on. This is an antibiotic that can help prevent or minimize the risk for lung infections, but also has anti-inflammatory properties. And when it's given to help treat lung GVHD, it's typically one pill 3 times a week. So many patients will take it on a Monday, Wednesday, Friday schedule. And then there's a medicine called montelukast. Its trade name is Singular. This is also used for asthma. This is a daily pill. And again, it's used for asthma or allergies, and it's also used for our patients as well. So many patients will be put on this on top of their other therapies if they have lung graft-versus-host disease. Moving on to systemic therapies for chronic graft-versus-host disease. Again, I want to mention that there are local and topical therapies. We always try to use those even when we're using systemic therapy to try to minimize our need for this systemic therapy so we can get off those medicines that have more global effects on the body and the immune system. Just like with acute GVHD, steroids are typically our first-line treatment. We do use a lower starting dose for chronic GVHD typically than we use for acute GVHD, but we use it over a much longer period of time, typically over several months. The side effects and the toxicities that we worry about with the steroids are the same as those that we worry about with acute GVHD that we talked about in an earlier slide. So beyond steroids, there are 3 approved medications for the treatment of chronic GVHD. I'm going to talk about those over the next few slides. The first is ibrutinib or Imbruvica. This is approved for patients 1 year old and older. It's a once-daily pill or liquid, but it does have a lot of side effects. There's a risk for bruising and bleeding and then tiredness. A lot of patients will have nausea and diarrhea. This can cause muscle spasms and does increase our risk for infections. So while this was the first approved agent, it's often not the first agent that we'll go to for treating patients that need another agent on top of or beyond steroids. Ruxolitinib, which is the same medicine that is used for steroid refractory acute GVHD, is also approved for chronic GVHD in patients 12 years old and older. This is, again, a twice-daily pill, and we have to watch blood counts, like I mentioned before, and there is a risk for infections with this. The last of the three agents is belumosudil, and this is a medication that's approved for patients that failed steroids plus one other agent. It's approved for, again, children and adults at least 12 years of age. It can be given either once or twice daily, depending on what other medicines you're on. And its most common side effects are nausea, diarrhea, fatigue, liver irritation or inflammation, and a risk for infections, although in my experience, this tends to be very well tolerated and these side effects are less frequent and less problematic. And we can also use this ECP that I talked about earlier, which is a collection of the immune cells by a machine from a patient, treating them with the UV light and then giving them back. This is the same treatment that we use for chronic GVHD. For acute GVHD, we can also use for chronic graft-versus-host disease. So I'd like to, there's also a lot of upcoming and experimental therapies. I want to specifically mention an agent called axatilimab that has completed a clinical trial with promising results. That's being reviewed for possible FDA approval. This is given IV every 2 weeks, but there are a lot of other experimental therapies that are under investigation, a lot of things that are being used off-label for patients as well. I'd like to quickly go over some brief physical challenges and emotional challenges in my few minutes that I have left with you. These are going to certainly be gone through in much greater detail in other talks as well. So I do encourage you to attend those talks. So when we talk about physical challenges from GVHD, we have to talk about medication side effects and problems from GVHD itself. And because chronic GVHD tends to be the more long-standing issue that patients deal with, I'm going to focus on chronic GVHD. For patients that are on steroids, this can cause muscle weakness, it can cause weight gain, and these are things that lead to patients just not feeling well, to not being happy with their body appearance, but also can hinder their ability to participate in their normal activities. For chronic GVHD itself, this can lead to limited mobility because of tightness of the joints or the skin. It can lead to fatigue, and it can lead to limitations in activity, particularly if there's lung involvement. For emotional challenges, steroids are one of the major ones that we worry about. This can lead to sleep disruption, mood swings, immobile, labile mood, anger, anxiety, things like that. And for body image issues, that can lead to emotional challenges. There's concerns about hair loss if that's associated with GVHD, the physical appearance of rashes and scarring of the skin. And with the steroids, these can cause acne and weight gain that can also be distressing to patients and make them unhappy with their appearance as well. There are a lot of treatments that can be used for these things to talk about with your doctors. The inability to fully participate in work or school also leads to emotional challenges to families and patients. And then for chronic GVHD, just the long-term treatment and the need to take medicines for a long period of time in and of itself does pose emotional challenges to patients as well. And last but not least, not just because of the potential for chronic graft-versus-host disease to involve sex organs, but also the body image issues, the stresses of transplant, everything like that can impact sexual health, which can be a significant impairment on quality of life for patients. So with that, that was a whirlwind overview and introduction to graft-versus-host disease, how we prevent it, where it shows up, and how we treat it. So with that, I thank you for your attention, and I welcome you to provide any questions that we can talk about in the remainder of our time together.
Thank you, Dr. Harris, for an excellent presentation. We will now begin the question and answer session. If you have any questions for Dr. Harris, please use the chat box on the lower left side of your screen and submit a question. We will try to answer as many questions as possible. Okay. We have a question. Have you seen any benefit from Rezurock as it relates to chronic lung GVHD, or is there any benefit primarily for other types of GVHD?
So one of the challenges with chronic GVHD is that it's caused by a lot of different types of immune cells, and it involves a lot of different pathways, biologic pathways in the body. And we're still trying to learn how to best decide which agents to use for each patient, individual patient, to maximize our chance for successful therapy for it. I have seen successful treatment of chronic GVHD of most organ systems by using ruxolitinib or from belumosudil, as from steroids and things like that as well. I was just this past week, over in Europe for the European Bone Marrow Transplant Scientific Conference, and there was talk about using that abatacept that we talked about that's being used to prevent GVHD as a potential treatment for lung GVHD as well. So the short answer is yes, I have seen ruxolitinib successfully treat GVHD of many different organ systems, including the lungs. We know from the clinical trials that some patients do have responses in the lungs, just beyond my experience. But every patient's experience is going to be different, and not every agent is going to work for every patient. So thankfully, we're having more and more different options for treatments that we can use for patients.
Can a sunburn, swimming in a chlorine pool, or another outside exposure to chemicals trigger your skin GVHD?
So that is a great question, and the answer to that is yes. Whenever we have irritation of the skin, that can be from a sunburn, that can be from chemical irritation, that can even be from a reaction to a new detergent or a soap or something like that. Whenever there's inflammation or irritation, the immune system goes and looks at where that inflammation and irritation is very, very closely. And after a transplant, that immune system, when it's looking very closely in those areas, it may find proteins in those different organ systems or those tissues that it doesn't like that are supposed to be there. It's just that they're from a different person. So those things can, in fact, be triggers for graft-versus-host disease. So it's very important to be wearing sunscreen and sun protective clothing after transplant to help minimize that risk, but our patients are also at increased risk for skin cancers as a late effect from their other treatments and from GVHD itself. And so it's important to do that lifelong to help minimize risk for skin cancers as well.
Can you discuss the pros and cons of using bone marrow versus peripheral stem cells for transplantation?
That's a very good question. So what I can tell you is there was a large randomized trial comparing bone marrow and peripheral blood stem cells from fully HLA-matched, unrelated, or stranger donors to try to get to the pros and cons of the two different graft sources. So I'm going to reference the findings from that study that has not been reproduced with sibling transplant or half-match transplant or any of the other settings, but we do try to extrapolate that somewhat to those other settings as well. I'm also going to focus on if we're giving a peripheral blood stem cell transplant or a bone marrow transplant where we've not manipulated the graft and taken out any cells or selected any cells in that. What we know is that if we use bone marrow instead of peripheral blood stem cells, it does decrease the risk for chronic graft-versus-host disease. And what was a surprise to us clinicians was that there was not an increased risk for acute GVHD or a decrease in relapse, because we know that there are more of those lymphocytes that are part of the peripheral blood stem cell graft when we give it. So the pros of a bone marrow transplant over a peripheral blood stem cell transplant is decreased incidence of chronic graft-versus-host disease. The benefit of a peripheral blood stem cell transplant is that we saw more reliable engraftment, meaning that the graft took. Now, the numbers of primary graft failures with bone marrow and peripheral blood stem cells were both low, but there was significantly less when using peripheral blood stem cells when compared to bone marrow. So I can speak to pediatrics where we tend to not have a lot of graft failure because we are using larger donors for smaller patients, particularly when using a parent or a stranger. Strangers have to be at least 18 years of age, and therefore they are adult size. For our pediatric patients, we get very good doses of cells. For adult patients, particularly those that are obese, sometimes getting a good cell dose can be challenging with bone marrow, and therefore they'll use peripheral blood stem cells and know that there is some of this increased risk. Now, some of this risk is being changed with more and more use of that post-transplant cyclophosphamide. And there's a lot of studies going on looking at how much that improves our risk for graft-versus-host disease after peripheral blood stem cell transplants. So that's, speaking specifically to, a P-replete or a non-manipulated perfectly matched stranger transplant, as opposed to these different other scenarios for a transplant, which we've not formally studied.
Is there a way to know if I have GVHD versus an autoimmune syndrome like A or Sjogren's?
So that's a very challenging question to answer because autoimmune conditions can occur after bone marrow transplant, but the fact that you've had a transplant and the immune system that's causing these autoimmune conditions is originally from somebody other than yourself. It's hard to say that it's autoimmune, meaning from the self, caused by the self, versus alloimmune, meaning coming from the other or from the donor. So these autoimmune conditions that are diagnosed, I personally think are still an alloimmune reaction and are one of the many different manifestations of chronic graft-versus-host disease. But this is a very controversial topic in GVHD. So when we see manifestations of an autoimmune disease that is not our typical manifestations that we think of chronic GVHD, we'll often work closely with our rheumatologists and immunologist specialists and colleagues to help with management. So that's a very controversial topic that I don't think we have a clear, straightforward answer for, and there are many strong opinions about.
How effective is photopheresis in your opinion?
So I think that it can be very effective in a lot of different settings. It's been looked at in a few studies, but it's more been kind of just given to patients, and then people have reported their experience and given it. The literature, there's a lot more literature than adults than in children, but the response rates that are reported in adults are anywhere from 40 to 50% of patients, and this is typically used in patients that have not responded ideally to steroids. And in pediatrics, those numbers have been anywhere from 45 to 70%. So this is an important treatment option that we do have for our patients. It is much more disruptive to their life than taking a pill or an intermittent IV infusion or an injection. But it's something that should be considered for patients that aren't able to tolerate those or that have not responded well to some of those. So in my experience, it can be effective, but the responses tend to be a little bit slower than some of these other medicines, so it's a big investment of time.
My donor was 100% matched from my sister. Does this increase or decrease my risk for chronic GVHD?
So she is saying that her sister was her donor and was 100% match?
His sister, yes, was the donor and 100% match.
Okay.
Does that increase or decrease chronic GVHD?
So there's a little bit of a mix in the answer to that. So we know that a sibling who is a full match is always our preferred donor, because it does decrease the risk for graft-versus-host disease compared to using a stranger or a half-matched donor or a less than fully matched donor. So that is why we prefer to use them, is we see less of these later complications and immune-mediated complications of transplant. When we look at our donors, if we have the option of a male versus a female donor for patients, particularly for male patients, we do prefer a male donor over a female donor, because the Y chromosome does make proteins that the immune system can recognize and attack. So when we use a female donor into a male recipient, there is a slightly increased risk of GVHD, or an increased risk of GVHD, than if we would use a male donor for a male recipient. But having a fully matched sibling is a better match than an unmatched stranger, and most people would prefer using a female fully matched sibling over a male donor if both are available. Because when we use a sibling, a lot of the proteins that we don't test for that can be recognized by the immune system are more likely to match up between the donor and the patient.
How do you differentiate acute from chronic GVHD if the timeline of occurrence could be overlapping? By pathology?
So yes, these are very different disease processes, and there can be some overlap and difficulty in distinguishing between the two. So historically, we called any GVHD that occurred before day 100 as acute, and anything that occurred beyond day 100 is chronic. But as we've changed how we do transplant, as we learn more about the biology of these diseases, we learn they're very distinct and different processes. So when we look at biopsies under the microscope, there are differences that we can see between the two. The hallmark of acute GVHD, particularly in the gut, is something called apoptosis, or programmed cell death, that's caused by the immune cells and the way that they interact with the healthy tissue cells. For chronic GVHD, we tend to see more fibrosis, which is a fancy name that, for better, all intents and purposes, is scarring. So we see more fibrosis in chronic GVHD. And then how the the symptoms present and the signs present of the disease also helps distinguish between the two. So one thing we're learning as we are doing more of these different types of transplants is that we can see more and more acute GVHD that occurs much later after transplant than we had historically seen. So we have to go by the constellation of symptoms and signs that we're seeing, and if we do biopsies, what we're seeing under the microscope to help distinguish between the two.
If you're having trouble staying off tacrolimus 2 years post-transplant, what other options would you have?
So it's very difficult to try to answer this question without knowing a lot more details of this case. I can tell you that calcineurin inhibitors are used very long-term at some centers and not at others. This is a better question to have with your particular physician. Especially if you're having challenges or complications from your tacrolimus or difficulty with taking it, it's good to explore what other options you may have with your transplant physician. And if you're not satisfied with that answer, you're always entitled to ask to see somebody else in consultation for a second opinion.
Okay, I have chronic GVHD of the skin. If ECP is given as a treatment, will it make it so the GVHD will go away indefinitely? Can you also discuss some of the long-term effects of ECP?
Sure. So one of the other GVHD treatments is that we will be able to use it to get a good response, but your ECP will simply go away. Anyway, one of the ways that we know ECP works is that instead of...
Pardon me, Dr. Harris, if you can hear me, this is the operator. I hate to break in here, but we have lost your audio.
Oh.
Please continue. Go ahead. There you are.
Okay. Sorry, I lost you guys for a second. So the question was about ECP and can it make GVHD go away? The hope with any of our GVHD therapies is that they will make the GVHD go away and we can get off, and I've seen that with many of the different treatments that we use for GVHD. ECP is a little bit unique in how it works compared to some of our other agents, in that we don't fully understand its full mechanism, but one of the things that we know it does do is expand some of our immune cells that lead to regulation and tolerance in the body. So the hope with ECP, along with a lot of these others, is that these cells that promote this tolerance will expand, grow, and ultimately lead to where we'll be able to be off other therapies, although that doesn't always happen for patients, unfortunately.
Do you find teeth sensitivity as a GVHD symptom?
So teeth sensitivity in and of themselves, I typically don't see as a symptom of GVHD. I worry more about gum and cheek and mouth sensitivity as a whole. I do worry about dental health in our patients with a lot of the treatments that they've had, especially in patients that have had radiation that may lead to teeth sensitivity. Having said that, it may be possible because GVHD can affect pretty much any part of the body, unfortunately. So if we are able to rule out some of these other things like small cavities or microscopic cavities from some of the treatments patients have been on, things like that, and we still have dental sensitivity, that may, in fact, be a diagnosis exclusion that we could make.
Is blurry vision a symptom of GVHD of the eye?
It certainly can be a symptom of GVHD of the eye, but there are a lot of other things that can cause vision blurriness as well. So for all of my patients that I see and treat for chronic GVHD, I do have them have regular follow-up with an ophthalmologist that is familiar with chronic GVHD along with the other eye concerns that we have. For example, patients that have had radiation therapy are at risk for cataracts, and those can certainly also cause blurry vision as well. So having good eye doctor follow-up is certainly an important part of ongoing care for patients with chronic graft-versus-host-disease.
Is there any treatment for GVHD-related hair loss? I'm 10 years post-transplant and still experiencing significant hair loss.
So there are some therapies that can be considered for hair loss post-transplant, whether it's related to GVHD or to other causes. Oftentimes, this is something that could be discussed with a dermatologist. I know the dermatologist I work with will prescribe things like minoxidil and finasteride, which are medicines that are used for other hair loss to patients and has seen some good responses. But I typically defer that management to her because that's much more her area of expertise than mine.
Does chronic GVHD burn out after a period of time in treatment?
So there are varying opinions on that. I think personally that yes, it can burn out. Now, one of the challenges with chronic GVHD is even if it's quiet, if it's caused significant fibrosis or scarring, some of that scarring may be irreversible. So even if there's not active attack and destruction or active progression of GVHD going on for chronic GVHD, there may still be lingering symptoms and issues because it was there. So I do think that GVHD over time can burn out, but it doesn't mean that all of the symptoms will go away, especially if there's significant scarring or fibrosis.
Does treatment for GVHD with immune modulators like Imbruvica cause cancer relapse in long-term use if you use it more than a year?
So I think I'm hearing two different concerns here. One is if we have to go on further immunosuppression, does it increase our risk for relapse of our cancer that we had our transplant for? And is there an increased risk for other cancers afterwards? Unfortunately, the answer for both of those is yes, if we have to go on higher doses of immunosuppression, it does increase our risk for both of those because our immune system is important first for treating our cancer, which is part of why we do a transplant, but also and then screening for cancer and precancerous cells in our body and killing them before they progress into a clinically meaningful cancer that we have to treat more traditionally. So unfortunately, those are risks. I can tell you that the development of GVHD also is associated with less relapse of the underlying cancer for which you had a transplant, but it doesn't take that risk to zero as well, unfortunately. So these are concerns that we talk about both short-term and long-term. It's why we do try to come off of these medications is because there are long-term risks with long-term use, and it's something that we're always mindful of.
Is there a connection between the increased infection rate and Rezurock because of immunosuppression? Do you have any recommendations to diminish infection rate?
So there's a lot of nuance to this answer because a lot of our experience using Rezurock, particularly for GVHD, is in combination with steroids or other agents that also can affect the immune system. There is a large body of literature looking at using Rezurock. Oh, sorry, we're talking Rezurock, not ruxolitinib. So for Rezurock, again, it's typically been used in combination with other agents or in patients that immune system is already fairly weak from having a lot of steroid exposure and things like that. In the clinical trial of Rezurock, which is probably the largest pooled experience that's been reported, they did see some slightly increased risk for infections of the lungs that can be both viral and bacterial. How immunosuppressive it is on its own is something that I don't think any of us truly knows just yet. So if people are on Belumosal or Rezurock just by itself, it's unclear what their infectious risk is because we just don't know. Having said that, we all worry because we know patients with chronic GVHD, their immune systems are not working properly to begin with, which is why most patients, when they have chronic GVHD, are on some form of infection prophylaxis. And so I think the most important thing is, close monitoring discussion with your doctor, talking about what the prophylaxis plan is. And if you do see that you're having recurrent infections, talking with your doctor about ways of trying to prevent those specific infections that you're experiencing, whether it's changing antibiotics, whether it's an antiviral, whether it's because you have low antibodies, you need IVIG replacement, or some other strategy altogether. So it depends on the infections that you're seeing, but Belumosal or Rezurock itself is something that, if given in isolation, I don't think we have a clear understanding of just how immunosuppressive it is. Certainly there is concern that it is affecting the immune system because we're using it to treat GVHD.
Okay, it looks like we can ask one more question.
Okay.
All right. We hear that a little GVHD is a good thing to help prevent relapse. Is this true?
So, yes and no. We know that a little bit of GVHD or GVHD and experiencing GVHD in several different diseases for which we do transplants has been associated with decreased risk for relapse. So a little GVHD, if it responds well to treatment, goes away and doesn't come back, is something that's okay. Having said that, GVHD in and of itself can be life-threatening. So a lot of GVHD is something that we worry about. So the other thing that we when we talk about this is when we talk about GVHD, we also have to talk about GVL, which is something I didn't go into, and that's the graft versus leukemia or graft versus cancer effect that we want from the transplant. we've not been able to separate GVHD from the graft versus cancer effect. And that's kind of the holy grail of GVHD treatment research, is learning how to completely quiet and silence graft versus host disease without impairing our that immune system's ability to fight off the cancer and other infections and things like that. So yes, that's an observation that is made, but I always worry that a little GVHD can turn into a lot of GVHD. So when GVHD occurs, we need to treat it.
Thank you, Dr. Harris, for this excellent presentation.
Oh, it's my pleasure, and I thank everybody for their attention and the wonderful questions and discussion we were able to have at the end.